Next, very important point is that 3% of the GCTs primary GCT, that means benign GCT, can metastasize to involve the distant organs. The 3% possibilities of metastasis into the lungs, because lungs are considered to be the most common distant organ for metastatic receiving. Alright. So 3% are the possibilities. But out of all the GCTs which could be prevented in distal femur, proximal tibia and any other location, distal radial GCT is most likely to spread into a metastatic lesion, and that too of the distal radius GCT. Hopefully you have understood the entire line, that first of all it is a benign tumor and it is not characteristic feature of a benign tumor to metastasize, but GCT is an aggressive kind of a benign tumor. The possibility of metastatic lesion is always there. So benign GCT can metastasize. Point number 1. Point number 2, the most common organ which is receiving this metastasis is lungs. Point number 3, it is the distal radius GCT which is most commonly leading to a metastatic lesion, not the distal femur or proximal tibial GCT, which is otherwise very common. Alright, so this is a line which is very, very important for your future related examinations. Next, what are the differential diagnosis of the GCT based on its X-ray, based on its clinical and histopathological appearances? The differential diagnosis involve the simple and the aneurysmal bone cyst, chondroblastoma, chondromyxoid fibroma, the giant cell reparative granuloma, the non-ossifying fibroma and eosinophilic granuloma. So these are the differential diagnosis based on the histopathological appearance, in particular for GCT. So they used to ask that which of the following is the closest differential diagnosis. The differential diagnosis which will, the DD of the GCT, which will almost appear like a GCT, it is aneurysmal bone cyst. So aneurysmal bone cyst is the closest differential diagnosis for giant cell tumor. So hopefully you have understood everything related to this particular tumor or this particular segment of the tumor, that is GCT. As far as the management is concerned, before we talk about the management, it is also important to consider one key clinical finding, and that is egg shell crackling on palpation. Eggshell crackling on palpation. If a patient comes to you who is having GCT, you are not aware that the patient is suffering from GCT. You are just palpating the swollen limb, you are just palpating the lesion over the skin. You feel as if you are palpating the shell of a cracked egg. This is a very important clinical feature for the GCT that you have to remember on palpation, that it feels like a shell of a cracked egg. Now we can talk about the management, the treatment. As far as treatment is concerned, yes, you have to go for extended curettage. That means not only the tumor, the normal peripheral margins of the bones are also needed to be excised. Then ablation, whatever means cryotherapy, by thermal cautery, by nitrous, you have to ablate the margins. After the ablation is achieved, it all depends upon the defect, it all depends upon the region of the defect, that whether it requires grafting and fixation or not. So most of the time the grafting or filling the defect with the cement is required, but whether the fixation is required or not, it depends upon the region which is involved. For example, if the distal femur is affected, so the patient will walk on this distal femur site, and if the defect is too large, then you have to fix it also in order to prevent the fractures related to that defect which is being created. Alright, so the fixation means it could be done or it could not be done. But yes, the principle of the management remains the extended curettage and the ablation, with or without grafting, with or without fixation. So this is all what you have to remember. As far as the management of this GCT is concerned, you see that no chemotherapy. Chemotherapy has no role in the management of a benign lesion. So chemotherapy as well as no radiation exposure, radiotherapy. Alright, only surgical management is the treatment for GCT. No chemotherapy, no radiotherapy, only surgical management. Because if you subject this lesion to a radiotherapy, for example, then the possibility of secondary malignant lesion will increase. The possibility of malignant transformation of this lesion will increase. So it should be avoided. Hopefully everything is clear or understood related to the giant cell tumor. Majority of the things we have already talked about, like soap bubble appearance on the X-ray is a feature for GCT. It is a tumor of a skeletally mature individual beyond 20 to 40 years of age. It happens. In GCT is an epiphyseal lesion primarily, But in rare of the rarest condition, it can happen in metaphysis also, but that too in case of a child, growing child. So this much you need to remember about the giant cell tumor. Next in the line of the tumor, we have the osteosarcoma, the most common tumor, primary tumor of the long bones, that is osteosarcoma. Now, before even we talk anything related to the osteosarcoma, based on the histological grades, the osteosarcoma could be divided into low grade, intermediate grade, and a high grade tumor. So you should be aware of what are the low grade osteosarcomatous lesion, because there are several. It's not like in case of Ewing sarcoma, for example, all the tumors are of high grade tumor. But in case of osteosarcoma, there is a low grade tumor also. There is a intermediate grade tumor also. So low grade tumors are like parosteal, central. These are low grade tumors. The intermediate grade is periosteal osteosarcoma. But rest, like conventional osteosarcoma, is a high grade tumor. Telangiectatic osteosarcoma, secondary osteosarcoma, which could be because of Paget disease, is a high grade tumor. Radiation, small cell osteosarcoma, all of them are high grade tumors of the osteosarcomatous lesion. Now, as far as associations, every time you see a question related to osteosarcoma, they will ask you about the association. You have to remember these three associations related to osteosarcoma. The first one is retinoblastoma. If a child is presenting with retinoblastoma, then the possibility of secondary osteosarcomatous lesion will always be there. So, retinoblastoma is one. Second is Lee-Fromeny syndrome. So, this Lee-Fromeny syndrome is another association. All of you know what the Lee-Fromeny syndrome is, where there is a higher incidence of familial breast cancer, particularly in case of a young female with familial sarcoma. It happens in case of Fromeny syndrome, and it is because of the p53 gene mutations. And finally, the Rothmund-Thompson syndrome. And these are the features of the Rothmund syndrome. This is the third association. All right. Like there will be poikiloderma, stunted growth, juvenile cataract, as well as skeletal abnormalities. So these are the three associations you have to remember: retinoblastoma, Lee-Fromeny syndrome, and Rothmund syndrome. Next, bimodal peak of incidence. Why there is a bimodal peak of incidence? The reason is the primary osteosarcoma, the age is 10 to 20 years of age, which we have already talked about. But for secondary osteosarcoma, the age is 50 to 60 years of age. Like in 40 to 60 years of age category, we have talked about this in age predilection also. So it will be around 50 to 60 years of age. That is how a bimodal incidence or peak in the incidence of osteosarcoma. All right. So this primary in lesser age group, secondary in a greater age group. Then as far as metastasis is concerned, lungs are the most common receiving site for these metastatic lesions, and the bone is the second most common site. All of you know about the skip lesions. Skip lesion is bone to bone metastasis. If there is an osteosarcoma in the distal end of the femur, which has metastasized to involve the proximal aspect of the femur, so that will be a skip lesion. So bone to bone metastasis is also a common phenomena, which is the second most site for receiving these metastatic lesions. As far as the causes of secondary osteosarcomatous lesions are concerned, it is a very, very important table for you to remember. And you also have to remember that multiple of the time they have asked this question based on chronic radiation exposure. They have asked this question based on Paget disease. They have asked this question on bone island. They've asked this question on GCT. All right. So what are the causes? Paget disease. All of you know osteitis deformans. It can emerge as a osteosarcomatous lesion, secondary osteosarcomatous lesion. Radiation induced, fibrous dysplasia, osteochondroma, even the chronic, long-standing chronic osteomyelitis can lead to osteosarcoma. Then osteogenesis imperfecta, GCT, and the bone infarct. So these are the conditions, primary conditions of the bones, which can result in secondary osteosarcomatous lesion. As far as your questions are concerned, Paget disease, chronic radiation exposure, GCT is something which they have already asked about. Next, what are the poor prognostic factors? Whenever we talk about the poor prognostic factor, these prognostic factors are discussed in relation to or in context to the conventional type of the osteosarcoma. We are not talking about the low grade or intermediate type of the osteosarcomatous lesion. That was just the distinguishing feature in between the two. So the poor prognostic factors which are included is the metastasis. Whenever there is a metastatic lesion, it will be a poor prognostic factor to bones, lymph node, as well as the primary receiving organ, that is lungs. Then expression of a P glycoprotein in the cell is considered to be a poor prognostic factor. Then high alkaline phosphatase, high lactate dehydrogenase, vascular invasion, the size of the tumor, no alteration in GNE ploidy after chemotherapy. When the patient was subjected to neoadjuvant chemotherapy, there was no alteration in the gene ploidy, and absence of anti-heat shock protein 90 after chemotherapy. All right. So if there is no antibody for, so this is something that which you have to learn, that all of them are considered to be a poor prognostic indicators for osteosarcomatous lesion. As far as management is concerned, neoadjuvant chemotherapy has to be given for the period of 8 to 12 weeks. That means around 2 to 3 months. Then maintenance of the chemotherapy has to be continued for about 1 year, and in between the surgical method is provided. Means you can go for the amputation, you can go for the megaprosthetic implant placement. All right. But you know, placement of the megaprosthetic implants over a period of time, we have realized that it is not going to have the best possible outcome. It is just considered as a palliative management of the osteosarcomatous lesion in particular, so that the patient manages to walk for the duration of time on his own limb. All right. Otherwise, 80% are the chances that within 5 to 6 years of placement of this megaprosthesis, it will get either infected, or it will be failed as an implant, or it will be having some complication which will require the removal of this megaprosthetic implant. All right. So megaprosthesis is something where which is considered for the limb salvage kind of a therapy, but ultimately in 80% of the cases what we have witnessed, that ultimately it is the amputation that you have to perform after some duration of time. So surgical resection or amputation, radiation is considered for palliation. This is also, we have talked about that primary osteosarcomatous lesion are radio resistant. So it is not required for the management of osteosarcomatous lesion. It is just considered as a therapy for palliation. All right. This much you need to know about osteosarcoma. As far as the X-ray findings, which are sunburst appearance, rising sun appearance, and the pathophysiological mechanism behind those appearances, we have already discussed about that. So if you look at the X-rays, if it is provided over here, next in the line of the tumors is the chondrosarcoma. You know, chondrosarcoma related 2 facts that you have to remember. The one, it is the most common malignant tumor of the small bones in hand. You know, the most common tumor of a bone in hand is enchondroma. But the most common malignant, because enchondroma is not a malignant tumor, most common malignant tumor of a bone in hand is going to be a chondrosarcoma. Although it is a very rare phenomena, but out of all the malignant tumor, chondrosarcoma is the most common malignant tumor for small bones in hand. Next is, this is the kind of the tumor which leads to hyperglycemia. Means 85% of the cases who are suffering from chondrosarcoma are also found to have hyperglycemia. So this is a kind of the tumor which leads to hyperglycemia in 85% of the cases, or is associated with hyperglycemia. These are the 2 facts that you have to remember for that particular tumor. The most common site for the tumor is the pelvis, and this is how the appearance of the tumor will be, like popcorn type of, spicule type of, inhomogeneous kind of the calcification which will appear. All right.